and I know that we will have more people joining. My name is Tamara Vesel. I'm a division chief of palliative care at Tufts Medical Center. And everybody, welcome to Palliative Care Grand Rounds of the um, of March. I can't believe that we will be watching spring flowers coming up soon. I don't know how it is in your neighborhood, but I'm already seeing some little bulbs coming up and saying, is it the time to come out or not? We had a very long winter here in Massachusetts. It's my pleasure and honor that we had Noya Shilo, a physician from Israel, accepting our invitation. Michael Eizyk, our fellow, discovered her. I wish I would discover her myself, but I can't take a credit for that. And pointed out about 6 months ago, this is a speaker we need to bring. And I was, I have to say, skeptical about it. My first reaction was, I don't have the money to bring her here from Israel, and she's too famous to accept this kind of an invitation. But as soon as we met, it became very clear that my doubts and my concerns were unfounded. So I will ask Michael, since he discovered you, to introduce you. And we are absolutely looking forward to have such an incredible guest speaker today. Oh, meanwhile, just few logistics. Whoever wants a CME, there is a code there, so you can sign in into the EATS, which we are part of, so you can get an hour's CME credit when you log into the EATS and type in 83 REIN. We would like you to be active, and our speaker is open if you type in your questions or comments to be interrupted or collect those questions. Michael will do them, and she will give us enough time to ask her questions and answer. One more thing is, just so you are aware, she is in Tel Aviv, Israel, and unfortunately, we may be interrupted. I hope not. If there is a siren, she will need to go to the shelter. So that would be one of the only reason when she will interrupt, and we will need to reconvene. Thank you for understanding.
It's truly my privilege to welcome Dr. Noya Shilo virtually to our palliative medicine grand rounds here at Tufts. Dr. Shilo is a senior physician in internal medicine at Sheba Medical Center in Israel, where she also serves as the head of the Back to Life Center, an interdisciplinary initiative developed to support individuals returning from captivity in the aftermath of October 2023. In this role, she has been closely involved in the clinical care and longitudinal support of individuals and families recovering from captivity, working within multidisciplinary teams to address complex physical and psychological trauma. Alongside her leadership at the Back to Life Center, Dr. Shilo continues her work within internal medicine at Sheba, contributing to the development of care models that extend beyond acute treatment towards recovery, rehabilitation, and reintegration. She is also engaged in advancing the role of technology in clinical practice, helping to shape how medicine can evolve to better meet the needs of patients, families, and communities. Beyond the clinical space, she is the host of the podcast Inside Medicine, where she invites clinicians to a shared space of reflection, exploring the inner life of medicine and the questions of responsibility, meaning, suffering, uncertainty that shape how we care for others and ourselves. In palliative medicine, we also find ourselves at the edge of certainty, accompanying patients and families through prognostic ambiguity, shifting goals, family conflict, moral distress, anticipatory grief, and the limits of what medicine can offer. We are truly grateful to welcome Dr. Shilo and to learn from her. Her lived and clinical experiences offer a perspective that can deepen how we accompany patients and families in our own community, especially in moments where there are no clear answers and where our presence matters most. With that, please join me in welcoming Dr. Noya Shilo.
Thank you so much, Michael and Tamara, for the invitation and for reaching out and for finding my podcast, Michael. So I want to tell you a little bit. I made a presentation to tell you a little bit about what's been going on in Israel for the past 2.5 years, what we've learned. Um, and it goes something like this. So I called this presentation Owning the Unknown, Medicine in Times of Crisis. And I want to address today 3 issues. The first one is to tell you about our experience in treating returned hostages, to tell you a little bit about our real life lessons, how we did it, what we discovered, what we learned along the way. Next, excuse me, I would like to talk about what we found in meeting complex trauma and the way it encouraged us to learn new things about medicine. I call it Medicine 2.0. And the third topic is creativity in medicine, something usually we don't talk about. Medicine is not a very creative vocation, in my opinion. And I want to talk about the notes and the variations. So let's start with treating the returned hostages, a topic that I never learned when I went to medical school. I don't think any of us did. Yet it was something we found ourselves confronting with, meeting, and having to deal with in the past 2.5 years. So really, when we talk about the returned hostages, timing is everything, because I've been doing this talk or talking about my work for a while now, and the narrative really changed before everyone came back. And now, when everyone is back, yet the war is still going on, the narrative really shifts according to what's been going on. When some hostages were back and some were still in captivity, we used our findings as doctors to be able to promote the struggle to bring everyone back home. And now we talk about our lessons, and there's some different perspective, and we see things a little bit differently. And timing is also everything in the sense of the work that we do, because only now, when everyone is back, we can start talking about rehabilitation regarding our patients. I want to tell you a little bit about where I work. I work at Sheba Medical Center. It's called the City of Health. It's really the size of the city. It's just outside Tel Aviv. It's the biggest hospital in Israel in the Middle East. We have 1,900 beds. Recently, we've been chosen to be the 7th in the World's Best Hospital Newsweek list. And it's a really privilege because it's a place to do many things differently. Like everyone else in Israel, on October 7th, we met an atrocious nightmare. I was on call. I was actually at Sheba on the day of October 7th. And this is a picture which was taken in the ER in the morning of October 7th. You can see everyone's very busy, but you can also see the anxiety and the fear and the shock and the chaos, which is such an event is always accompanied by. And I think that something very different was going on that day, because as healthcare crew, when we treat our patients, rule number 1 is the patient is sick, I'm okay, right? Even in the house of God, they tell you to take your own pulse when you start CPR. But here, the disaster was of everyone. So we were here, and some of these people didn't know where their family members are. I was on call, and the resident that was with me was actually taking to reserve duty during his call, and I stayed there to replace him. And there are some that are so much more damaged and hurt and injured and traumatized by others. But the entire country of Israel is traumatized, and the entire Middle East, unfortunately, is going through very, very deep trauma. In the first few weeks after October 7th, first few days, it was discovered that there are people taken hostage. And we started preparing for the return. Here you see 3 of them. 2 of them we treated here. Eli Sharabi, who later wrote the book Hostage, arrived at Sheba. And we understood that people in very, very bad shape are going to be brought back home. We know that they will be brought back home, because if they wouldn't, we wouldn't be Israel. So we started preparing very early on to the return. And they started arriving. This is the ER on February 24 on the first rescue of Fernando Nauman and Luis here. They came back and we treated them. And these were the most emotional scenes you can imagine. On the left, you can see the chopper coming down with the hostages brought to the hospital. On the right, you can see the departments that we made. The sign says, "It's so good that you're home." Hope without boundaries, which is the motto of Shiva. And you can see it's very homey. They put couches and it's all very colorful. And we tried to do the best to treat these people when they arrived. And at Shiva, all in all, we treated 57 returned hostages in 6 rounds of return. This was something like we've never done before. As I said, no one ever taught me how to prepare for people returning from captivity, for people taken hostage from their own homes, from their own beds, children, babies, elderly, men and women. No one taught us. And there was really no reference. So we started with a very basic. We asked ourselves, what really is our mission? We asked very basic questions like, who are our patients? Who are they? What is their trauma? Because there are so many layers and so many components to the trauma in such an occasion. What is their trauma? Next, we asked ourselves, what do they need? And then we asked, how do we meet these needs? And all these questions are rarely asked when we're in the hospital, right? Who are the patients? The ones that come to the ER or the ones that come to the clinic. What is their trauma? We ask for their main complaint. This is what we treat. What do they need? We go to the literature. We go to the evidence-based medicine. And it's very clear how to meet their needs because there's a whole system that was built to do it. And here, none of this was very obvious and clear. So we started answering the questions. We said that our patients are, of course, the returned hostages, but also their family members. I have the great honor and privilege of working with one of the most renowned psychiatrists in Israel, Dr. Michael Pollack, who has been treating PTSD soldiers and returned hostages from past wars for the past few decades. And very early on, Mickey said, when a person is taken in captivity, their entire family is taken in captivity, and we need to treat them all. Usually we treat patients who are on their list in the EMR, but here we're going to treat them all. Next, we said they have very different traumas. Some had gunshot injuries that were neglected for 2 years. Some had chronic disease neglected. Some were starved more than others. Some were immobilized for months. But the common denominator is that the trauma was of the body and the mind and the spirit. We understood that what they need is very flexible solutions. They need it to be a one-stop shop because they cannot be disturbed with different things in different locations, and it has to feel like a home. And they need their team to work together transdisciplinarily. We have to work together and to create a new profession. And we understood that the name of the game, or maybe that the ground, the root of everything, is that our medicine has to be holistic, has to be whole, has to be holistic. This is what they need, and we need to find a way to do it. And in that, really our mission became our calling to reinvent medicine. And we set out from there to understand how we do it. How do you make such a solution? How do you build this? How do you reinvent medicine to meet such deep pain and complex needs? And we created a model that we call it the flower model. So at the core of each flower, we have the patient with dual case management. So each patient has a psychiatrist and an internist, along with a case manager nurse, or a pediatrician and a children's psychiatrist. And we see our patients together. We understand things together. I want to give you an example. We had a patient whose main complaint, a returned hostage, an elderly lady, whose main complaint was shortness of breath. And I examined her. This is my jurisdiction as an internist. And I examined her, and it was stridor. And I had a whole hypothesis of what is causing that stridor. And I had my ENT specialist and my pulmonologist working with me and giving consults. But when we sat with her, the psychiatrist and me together, and we sat with her, she said that the stridor, the very physical, biological complaint, becomes worse when she goes to the bathroom or into the elevator to a confined place that reminded her of the confined cell that she was held in when she was in the tunnels in Gaza. And this is the kind of depth that I never went into when I was an internist working in internal medicine department. And it is never anything that used to come up in a psychiatric clinic. And it is something that came when we sat together and asked questions together. And when we sit together, our conversation includes a lot of questions that we ask each other. I ask Mickey, what do you think? What do you think it's connected to? And many things we understand when we are together. And out of the core of the flowers, petals grow and shed according to the patient's needs. And here I always say that I went shopping in the huge Costco that is Sheba, and I just loaded my cart with everything I could find. All the classical medicine like cardiology and dentistry and oncology and OBGYN and orthopedics and everything you can imagine. And all kinds of mental therapy as well, not just psychology and social work, but also music therapy, art therapy, and logotherapy, the method developed by Viktor Frankl after the Holocaust. And everything from the rehabilitation arena, like occupational therapy and hydrotherapy. And of course, alternative medicine as well, like reflexology and acupuncture. And for each patient, we create their own team. So just to give you an example, we have a patient who's endured gunshot injuries, and she had to undergo several surgeries. And in her flower, there's an internist, a psychiatrist, an orthopedic surgeon, and a reflexologist, all working together as a team. And we remember that each flower is unique. No two teams are alike. Each patient has their own needs and needs the palette, the scale of to be fine-tuned exactly for them. I want to give you a little bit of numbers because it sounds very vague. I want to tell you about 2025 in our center. So we have now over 220 patients, but when 2025 ended, we had 203. About a third of them were returned hostages, and the rest were family members of all circles. And many of them are not acknowledged by the authorities in Israel as patients that endured trauma, but we know that they are. Because, when we talk about first circle, it makes more sense. And people say, what about second circle, third circle, like cousins, grandparents, grandchildren, in-laws? But in some families, the first circle was murdered and the second became first. And in some families, the first circle is in bed, unable to get out because they're so deeply depressed. And the third circle had a person who took over, and they all need to be validated and acknowledged and treated. We also treat family members of deceased hostages. We also treated family members of hostages while they were still in captivity. We say yes to everyone. We had over 900 visits at the Back to Life Center, which I run, and we had almost double as that Sheba appointments. If they go to the dentist, if they go to the OBGYN, if they go to the hydrotherapy, to the therapeutic pool, swimming pool. So we had almost 1,500 meetings of those. And now we have over 100 team members from Sheba, all professions, all of them are seniors. And we give them all training in trauma-informed medicine. We have a support group for the team, meeting every week. we give ourselves lectures and we educate ourselves about what it means to deal with patients who have endured such unbelievable deep trauma. And this is our clinic. I'm actually sitting here right now. And I want to tell you something because I think it's very symbolic that we're here and this is the palliative unit. Our clinic is located at the Friedman building in Tel HaShomer in Sheba, which is the hospice. The floor above us is the hospice. And when we needed a space, they offered us a few options. And they said, listen, there's one place that we don't know if you'll want because it's in the hospice, but it's available. And I went there to have a look. This was actually a storage room. And I saw the potential immediately because it's so well lit and there's the yard, the patio, and it's so nice. And this building was actually designed by one of Israel's most famous architects, Ada Karmi, who actually designed the Supreme Court as well. And I thought this would be so symbolic to share a building with a hospice. And because palliative care and us have so much in common. Death is present. Holistic medicine is a need. We see the patients through things that we might not be able to cure, but we're still with them. And palliative care is such an inspiration to me that I thought it would make perfect sense to everyone. And to my awe, our patients understand it as well. And when we tell them, listen, come to Friedman Building, and when you look it up, it says the hospice, it makes perfect sense to all of us. And I think maybe there's something so deep in the fact that Back to Life Center shares the same space with the hospice. We opened just now, a couple of months ago, and we keep on growing and growing. And I want to tell you a little bit about our plans or possibilities when we look ahead for the next decade. First of all, Israel is very small compared to the US, but still some patients are hours drive away from us. And we want to be able to bring our medicine to them as well. So we're looking into a few options of creating a network throughout Israel for the returned hostages and their families. We're thinking that many more medical centers worldwide would be interested in what we're doing, and we want to develop global partnerships. I personally believe that the way to create a change is through education, and we're looking into options to integrate these methods and insights and understandings into medical schools as well. And we want to broaden the scope because other medical arenas include complex trauma as well. So this is a little bit about what we've been doing in the Back to Life Center so far. If there are any questions, I would be happy to answer them. And if not, we'll go back, dive into complex trauma and what we understood when we met it. Maybe we'll go on. So I want to say something about meeting complex trauma. Tamara, do you want to say something?
May I just ask one question before you go?
Sure. Absolutely.
Can you just explain about the as you started this, or you thought about, let's start it, as you mentioned, with the first patient who came. Was it something you were told to do? Did you get funding? Did you get ordered to do it? Did you go to the administration? Like, can you just tell us the backup story of that for a second?
Yeah, of course. So this is really, this was something that was really bottom up, the way it was constructed. So we had 6 rounds of return, as I said, and the first one, we were instructed to discharge them home and have their GP take care of them. And this is something that is very common in Israel. We have a very strong public medical system that's spread throughout the country. And they said, just pass them on. And we did. And then after 3 months, we had our second round of return, which was a rescue. And it was a very moving privilege to see a family reunited because we had 3 women reunited with their men, and we treated the women when they came 3 months earlier, and then we saw them all together. It was very moving, and we asked them, "How are you?" And we understood that some of them are doing better than others because their community was still intact and their GP was there. And some of them, especially from the areas around Gaza that were endured the most atrocities, didn't have their communities and didn't have their GP. And they were dealing with very, very complex problems that had no solutions. And during that time, that return, we're sitting in the Back to Life department, and I was told to start a clinic. And I didn't know anything about a clinic because up to then I was working in a department and I never worked in a clinic before. And I said, I don't know how to do it. And I said to Miki Polak, you're coming with me because I don't know how to do it. And they said, the head of Sheba said, we need to do this. You do the best medicine you know how to do. We'll give you every kind of resource that you need, and we'll take it from there. And I think this was really rooted in the guilt that we all feel, the survivor's guilt.
Yeah.
And the compelling need to really try and give them, we cannot make it up to them, obviously, but to give them the very best medical care we can. And slowly, this grew very slowly, gradually, step by step, and we grew and grew, and we found the resources, and we created the partnerships, and there's a lot of philanthropy involved in this, and we're learning our way as we go along.
So Noya, you said something interesting, survivor guilt, but at the same time, if you are feeling survivor guilt, you are seeing yourself in the patient as well, more often than usual as a physician. Can you talk about that a little bit, and then we'll let you go with your plan? But, it just strikes me that potential trauma for you as a clinician is much higher than under normal circumstances when you think, oh, it could be me who will have a cancer, but then you can talk yourself out, but I don't. But this is much closer to it could have been me.
Absolutely. I think there's no one person in Israel who doesn't have survivor's guilt, including the hostages themselves, the returned hostages. And I think I talked about it before when I said that this is really a joint trauma of everyone. This is not me saying it's not about me, it's about them, because it's about them, but it's happening to me as well. And we have a department at Sheba for the returned hostages upon their return. So it's opened and closed each time we had a return. And I'm the head of that department. And my head nurse, Mari Zendel, lost her daughter in the Nova Festival. And we're all traumatized by this. We all have family members who were evacuated or in reserve duty, in the battlefield, in the trenches. And it affects everyone in Israel. And I think that on the one hand, it's very confusing and it's hard, it's very delicate to keep your balance and say, okay, it's happening to me as well. I was awoken by 3 alarms last night as well, but I'm still the physician. And to keep my role and maintain it, so it requires a lot of awareness for my job and for my obligation and responsibility. And at the same time, I think it did us a great service of bringing us and our patients closer together. Because when you consider the magnitude of this disaster that Israel is going through, the differences between us as patients and physicians is so small, smaller than ever. And we can really see each other as human beings. And I think it's the secret ingredient of holistic medicine.
So you think that your feeling for empathy is heightened because you were so close to the experience?
I think it's a very big question. I would like to think so, but I don't know. Time will tell. I think my ability to understand my patients, even though I cannot understand or begin to fathom what they went through. But my ability to understand patients in Israel, everyone I treat, not all my patients are returned hostages, they're family members. I still practice medicine as an internal medicine physician. I think I want to believe that we will have more empathy for our patients and for human beings after having gone through such a
Thank you
an
for being
experience.
so honest answering the questions. I will let you talk. I do have one thought, but I think that it's to answer after the two, and it is how this is different from Holocaust survivors.
First of all, there's a lot of there's a huge common denominator, and in our conversation, we bring up the Holocaust all the time.
Thank you.
And Viktor Frankl is here with us. Our books are in the clinic. We have a logotherapist working with us, and it's there. I think the main difference for Israelis is we thought that Israel was founded so we will always have a safe place. And on October 7th, we realized that Israel is not safe for us either. And this was a breach in our trust and confidence in the world. And the Holocaust is there, lessons from the Holocaust are there, and it's very present in our everyday work.
Thank you.
A little bit about meeting complex trauma. I'm not going to talk about complex trauma hardly at all, but as I said, meeting complex trauma is meeting the unknown. And many things are complex trauma. Of course, the extreme of being taken in captivity, being taken hostage, being in captivity is a very, very complex trauma, but it's not the only thing that's complex trauma. Autoimmune diseases, cancer, car accidents, neurological, neurodegenerative diseases, all of those share a lot, many deep aspects of complex trauma as well. And we know that what saves us every time is teamwork. And this is not just a slogan, because when we had no literature and no guidelines and no protocols to rely on, we relied on each other. We brought the best experts of the medical world, the mental and the physical, at Sheba and in Israel, and we started working together as a team. And I want to say something about teamwork, okay? We know there's discipline and there's multidisciplinary. When we have two people working together and maybe meeting up at the coffee place and sharing views, and there's interdisciplinary where we actually integrate part of other professions into our discipline and make it more deeper. But our work is transdisciplinary. It transcends the discipline. We created a new profession. You can call it treating returned hostages. In Hebrew, it sounds better. You can call it treating complex trauma. You can call it the medicine of complex trauma, but it's really a transdisciplinary profession, because when we work together in such teams, in such heterogenic and rich teams, we learn a lot from each other. I know so much more today that I didn't know before, and it shapes the entire way I approach patients and the way I practice medicine. And this is really transdisciplinary. And I think that transdisciplinarity is really the core of what we're doing. When we have nothing else, what we have is each other. And I think that the uniqueness of our work, of our center, is to be able to transcend each specific profession and create a new profession, which is really wider, bigger, and deeper than the sum of its parts, and can serve our patients in a more, in a wider, new, different way. Should we stop for questions before we go to the part about creative medicine?
Let us find out.
Okay.
Any questions from audience here? Michael can pass the mic Or there's one from Dave Sherman. To me, the greater symbolism is the name of the building, treatment building, however it's spelled.
Unbelievable. I never thought about it.
Thank you, Dave.
True.
Yeah,
I didn't even think about it.
Yeah, and the question is, when they hear that that you are in the building of hospice.
Treatment building. I never even thought about it. Unbelievable.
Do they get
So
scared?
symbolic.
Do some patients can get scared, like, I'm going to the hospice, or you don't hear
So I have to tell you, first of all, the name hospice is kind of alarming, as we all know. It's a word that holds a lot of deep meanings, hospice. But it's even more than that, because we're in the building and we share the shelter with a hospice.
Mm-hmm. Mm-hmm.
And when we have patients here and a siren goes off, I tell them, listen, we're going to go to the shelter together. And you should know this is the hospice. And they bring patients in. Because, a hospice is a place that people come as to end their lives with a terminal disease, but they don't want to die alone in a bombing.
Yeah.
So we help them to take the beds into the shelter. And I tell my patients, I explain to them that they might see their people who are in the hospice. They can have jaundice, or they can be very thin, or they can look sick. And we are used to that as physicians, but other people are not. And it's really, the other day was yesterday. I had one of our patients and his wife coming over, and a siren went off, and we went to the hospice shelter. And family members of the patients started talking to them because, some of the returned hostages are very known in Israel. And they asked him, "What are you doing here?" And he told them, "My doctor's here, and I came to the clinic of the returned hostages." And it started such an emotional conversation, which ended with a hug. And it's part of life. So our patients are getting used to the fact that we are here, and we explain it to them, and they accept it, and they own it like we do. And they're very proud, I think, of the clinic that they have here. So it's part of the complexity of life.
And, in a way, what is interesting about it is that it allows this cross conversation, right?
Mm-hmm.
Survived, but were worried about dying for so long. And then people who are facing their mortality and families in between, right?
Exactly.
Meeting people on such a human level
Exactly.
can be healing in a way. If you have a good
I agree.
facilitator like you guys are, noticing those interactions.
Yeah.
Any questions here? Everybody is very somber in the audience. Which, it's to hear your daily life right now. It's hard to hear. It's very hard to hear. We are used to caring for people who are very sick and at the end of life, but this is.
I had a question, if there's space. Hi, my name is Beth Nadich. I'm a chaplain in Boston, Massachusetts, at Heber Senior Life. I wanted to ask about something you just mentioned, about how so many of the hostages are known in Israel. I feel like I know everybody's face personally after 2 years. I thought about this a lot as people were returning. They left as just regular citizens and they came back as household names with people who care about them so much, but also believe that they have claim to their stories. And I wonder about that aspect of it in your treatment, about people's adjustment to coming back to an entirely changed world and an entirely changed role within that world.
So it's a very good question. First of all, I want to say that this was part of the struggle and was a strategic decision of the family members, to make them a household name, to have their faces in Times Square, to have us all feel like their own family, that they are our own family, and fight for their return, like they are our children, our siblings, our spouses, and so forth, our parents. And this decision was made without their approval, without their permission, right? And when they came back, we knew them. They didn't know that we knew them, They didn't know it. They didn't, and it took them a while to realize that they're so famous throughout the world and that this is not going to go away ever. Because you can't take things off the internet, right? So this is actually something that we addressed. And I have to tell you that during therapy, I'm sure that there's something that comes up. And it's very individual because and it is so complex because some people just wants to go back to being anonymous, and they're not. And some people always wanted to have a voice and always wanted to be recognized and always wanted to be heard. And now they have that. But due to the worst thing that ever happened to them, and it is so hard to make sense out of it. And this is something that we make room for, but I'm very humble, not to say that I know how to instruct them. I'm very clear about what I know and what I don't know, about what we know and what we don't know. I can't give them recommendations because no one knows. I also want to tell you that most of my patients are completely anonymous, and they feel translucent and they feel transparent because they can be the brother or the sister who are the next door neighbor, and by chance or luck or miracle, or you call it whatever you would like, they were not taken hostage, but they went through something horrible, but no one knows it. It's very, very complicated. I can walk with them in Sheba to go from one clinic to the other. I just walk them to whatever. And they have like people stop them asking for a selfie. Or worse than that, people stop them, tell them, "You look so familiar. Who are you?" That happens too. And it's something that is, it's like it's the elephant in the room. And when there's an elephant in the room, the first thing to do is to introduce it. And we talk about it. And we try to be with them and help them make the right choices for themselves.
You know,
I have a question, if I could.
Can you hold 1 second? We will just read the one and then you are next. Is that okay?
Sure.
Michal Scarf, who is a palliative care physician, dear friend of mine from VA in Boston, wrote, may I read it, Michal? My brother lives in Jerusalem, and I had not thought until now about the reality of bringing hospice patients to the shelter several times in one night. I just can't imagine. That's unbelievable, right? That's the time
unbelievable.
They should be in a serene, nice, calm environment, and their living and dying is interrupted. Thanks, Michal, for thinking of those people who are suffering in the middle of war. In the world, you are next. I'm so sorry, I didn't catch your name.
It's hi, Eric Richmond from Cummings School, veterinary school. I'm a social worker. I just wanted to get back to the hospice connection, and it's very interesting because obviously very different cultures between Israel and the United States, but in our country, it's a very death avoidant culture, and we don't like to talk about death, and so hospice
Us
is
too.
yeah, well, less so. Hospice is sort of off in the side, away from everybody, and you don't want your clinic near there. And even it's taken years for doctors to refer to palliative care and hospice, and we've come a long way. And I think about trauma, and I think about Vietnam veterans in our country. They were shunned, and for years they were not addressed. And you talked about survivor guilt, but there's quite a bit of shame involved in trauma. And I wonder how your clinic and maybe your country in general has been able to deal with shame in more of an open way rather than hiding away the people who were the victims. And is it the same for soldiers? My son was a lone soldier, and he came back recently from 2 years in Israel, and told me a few stories. And there are differences between combatants and what we see as innocent civilians. And so I wonder how you juggle all of that. I don't know if that's a question or just a statement.
Wow, you said so much. First of all, thank you for your son, for having him come here to protect us. Thank you for that. I'm sure it was very difficult for you, your entire family. I want to say a few things. First of all, in Israel, we avoid death as well. We don't talk about death as well. Sheba is very unique for having a hospice inside the hospital. It's also in the edge of the hospital, of the area of the vicinity of the hospital. And I'm kind of weird in the sense that I really love Friedman building for years. It's gorgeous. It's a very beautiful building. I appreciate the architecture. I love the atmosphere. It's an amazing place and amazing people work here. And, I think in Israel, it's not unique. It's very probably everywhere that real estate doesn't come easy. So when we needed a clinic, they gave us a few options of old buildings and remote places. And I said, no in hell that I'm going to have that as the Back to Life Center. And when they said hospice, the only vice of the place, which has so many virtues, is the fact that it's in the hospice. And in my opinion, it makes sense to me. As of what you said about the shame, I agree. There's a lot of shame intertwined in their stories. You asked about the soldiers. I don't treat the soldiers. They're treated by other team members at the rehabilitation center. But there's a lot of shame that comes up in the stories of our patients as well. And guilt and shame go together. And I think our job, or maybe the only thing we can do, is provide a very safe, secure, patient, and generous space for everything that needs to come up. And this is what we try to do.
Thank you, Noya. There are two more. I see Dave Sherman raised your hand. Can you unmute yourself and ask the question? Dave?
Yes, thank you. It strikes me that two things are true. One is that perhaps, as it's said in war, the only winner is medicine. And the other is that there's a tremendous intentional ignorance in much of the world about the trauma that these hostages and their families went through. And I think that the world would benefit from A, knowing about that, and B, knowing exactly how Israeli medicine has responded and whether or not it's worked. And so I wonder if you could perhaps give us a case study of, anonymized, of course, of some of the trauma that somebody has gone through and what you've done for it and how that person is doing. I also have an administrative question, which is, I'm told that I need to ask somebody named Wendy Pamalis about it, and I don't see her on the participant list. So I wonder if the person that introduced you, Dr. Shilo, might be able to post that information in the chat.
Dave, if you don't mind, I will put Wendy's email and we'll communicate, or you can email me.
Thank you.
Thank you so much. It's an administrative issue that we'll look into. Thank you for your.
Thank you.
There's another text here. It's thank you, Dr. Eizyk, for inviting me. I am his friend and prior co-resident family medicine. My question is, what brings you hope? And I suspect it's not to Dr. Eizyk, who right now is half hopeful and half hopeless, but it's to you, our main speaker.
What was the question again, please?
The question is, what brings you hope in this situation?
Okay.
Maybe what brings you hope and what brings other people hope?
Okay. Wow, wonderful questions. And I still haven't responded to Dev's question. I just want to say in the line that I think in Hebrew we say Or LaGoyim, maybe our light. I think that in many ways, medicine is the light of many things. And you know that throughout this war, Palestinian children kept on getting their treatment at Shilo in the past 2.5 years. And Syrian refugees were treated by medical teams, Israeli medical teams. And I really think that medicine, aside for the clinical doing, which is so important in the clinical work, can really be a bridge, serve as a bridge to overcome conflict. And I really hope that we can find a way to do it. And this is part of the reason that I come here today to talk to you. And there are many examples of the medical details of what we've done, what we found, and how we treated it. But I think it's a whole different story. It's a whole different talk. And maybe we can find a way to do that too. And as for the question of what brings me hope, first of all, I want to say that I'm hopeful and optimistic. And I want to say that I have the privilege of being hopeful and optimistic. It doesn't mean that I don't have my moments of despair, because I do, like everyone. But I'm hopeful and optimistic because of two things. First of all, because personally, I am very lucky to have a job and I can do something. There's something I can do in this terrible situation. People were so hopeless because they didn't know what to do with themselves. They didn't know what to do. And they couldn't find themselves in that feeling so helpless. And I, for some reason, had the luck of being in the right place at the right time and getting this job. And it really saved me. And it helps me being hopeful because I'm active. I have a job. I can do something about that. And when you feel very passive, it causes a lot of pessimism. But when you're active, it leads to hope. That's the one thing. But more than that, what makes me hopeful is our patients. Because we see so many inspiring examples of post-traumatic growth and people overcoming the worst of things. And people, if they find hope, who am I not to?
Yeah.
And really, and we hear tragedies and horrible stories and unbelievable pain and suffering. And at the same time, and people with fully blown PTSD with all the symptoms you can imagine. And along that, people who have found their spiritual side and are growing and found purpose and meaning. And this really resonates with Viktor Frankl's work, with Dr. Frankl's work. And it keeps me hopeful. I hope this answers the question.
And I hope that you can keep that hope and instill it in people who survived, obviously.
Yeah.
And what I'm hearing is comparing to Holocaust. I'm sorry, I'm from the family of Holocaust survivors, so I'm seeing some analogies. It's the ability of the medical system where you are, and perhaps you're looking ahead, is to give the opportunity to the survivors to share their stories. Because the stories of survivors of Holocaust decades later, after there was just so much silence that they just couldn't get the story out anymore. It was just so embedded inside of their souls. So I think that what you are saying, if we have nothing else to give, but we just open them to sharing, or we give them the space to share, it's not just. This is huge, Noya, huge. Thank you for that, and thank you for sharing that. I would like to read another one. Are you ready for one more?
Sure.
There is a longer note from Eizyk. Hello, I'm a surgical resident here. When we have trauma patients, sometimes we consult palliative, if needed, sometimes not. I was wondering if you could talk about the relationship of injury to people's experience. Some injuries have even been inspiring, such as Demar,
Damari.
the lost of places online in emoji and in my WhatsApp groups. Also, I was wondering about the resilience and trauma experience among medical professionals, including you and your colleagues and surgeons who are seeing a lot of trauma. Thank you for your question.
Thank you. So I want to say, and maybe this will refer to the previous questions as well. Basically, medically, what we've seen, physically, I mean, are three groups of problems. The first one refers to the last question, and it's gunshot injuries that were neglected for months and years. And when they arrived, they required a series of surgeries. And Emily is one example, but she's not the only one. And there, it's very complicated. First of all, because there's no medical experience about such neglected gunshot injuries, and how much of the damage is permanent due to the neglect, and how much can be restored, no one knows. And it goes through a very rigorous series of surgeries. The second group of things that we treat are chronic prior diseases, especially with the elderly, that were neglected there. One of the returned hostages that came back to Soroka Medical Center was in hypothyroid coma, myxedema coma, because she didn't receive her thyroid medications. But we saw many medications, many chronic diseases being neglected and deteriorating due to it. We see that, by the way, a lot more in the family members that we treat, because they had no spare time or really patience or will to treat themselves. And we have people that were diagnosed with advanced cancer because they didn't notice the early signs and didn't do their screening, or diabetes with hemoglobin A1C going through the roof, or many of those end organ damage of diseases that were neglected. And the third medical thing that we had to treat is patients who've been through the atrocities of captivity, starvation, lack of mobility with no muscle at all when they came back, very malnutrition, with very severe deficits in vitamins, recurrent infections due to the terrible conditions and reoccurring gastrointestinal infections and so forth. So these are the things that we treated. I want to refer to the question about how it affects us. And in a deeper way, I feel that what we're doing here is an opportunity to reinvent medicine as far as the caregivers go as well. And many times in medicine, the transparent populations is the caregivers and how it affects us. And it leads to burnout, and it leads to secondary traumatization, and it leads to compassion fatigue. When we don't give room for us, and what happens to us when we practice medicine in such conditions. And such conditions can be the everyday overload, which we experience everywhere in Israel as well. And it can be meeting such terrible, terrible, horrible, painful stories. And it leaves its mark. It leaves its mark on all of us. And I think that my job as the head of the center, for the people who work with me, over 100 of them, is first of all to give them the tools. So we educate each other. We have training, we have lectures, we give ourselves skills and tools and knowledge and the things that we need to be able, because the occupational therapist can hear the stories that the patient doesn't tell the psychologist. And they need tools as well. And the other thing is to make room for us to heal as well. So as I said, we have the support group once a week, and we do various things. We had a group that we did windsurfing together, therapeutic windsurfing. They took 10 of us and made us able to surf the waves. Unbelievable. Wave surfing. And we had in a wonderful foundation in Israel called the Gal Shili, My Wave. And we're going to start a phototherapy, a photo voice group of the crew members. And we try to make room for what we're going through on this mission and be able to process that and digest it together and be able to grow from it as well as therapists.
Thank you. And Noya, we are running out of time. I wish we could have for longer, but we need to get you out of there too, to your family. There is more thank you there from Hannah. Thank you, Dr. Shilo, for your work and this talk. I'm grateful the info about this conference made in the way on WhatsApp for Jewish healthcare professionals. We didn't put it on, but I'm glad that it went out. And if you don't mind, we would love to thank you so much. And Michael would like to have last word. Is that okay with you? Or
I would, and sure. And I will skip the third part. I just want to finish with a poem, if I can, before, after Michael, as you say, if we can, if it's possible.
Absolutely. Yeah, I'll just extend my. It's just amazing to have you and to listen. I'm so grateful that you're able to come and share your expertise in this very unique area. And I think just the more that we talk about this, the more that the overlaps between that, what you're doing and the work that we do in palliative medicine and hospice and just caring for people in their most basic needs, both medical, psychological, and spiritual, there's just so much overlap. So I just really think that there's a lot of room here for further collaboration, and we'd love to keep learning more from what you guys are doing and being a part of that.
And we will give you the minute for the poem. I just wish, and I know it's a huge wish, but for a peace in Middle East.
Yeah, amen.
Please read the poem.
Amen. Yes, so I want to finish with a poem by Rumi, which I believe most of you know, but I want to read it. So it's a poem by Rumi. It's a dialogue between him and God. I said, "What about my eyes?" And he said, "Keep them on the road." And I said, "What about my passion?" And he said, "Keep it burning." And I said, "What about my heart?" And he said, "Tell me what you hold inside it." I said, "Pain and sorrow." And he said, "Stay with it. The wound is the place where the light enters you." The wound is the place where the light enters you. As really, I think, what makes me hopeful and optimistic and gets me going. And I think this is really the message that I want to have lingering on to this wonderful conversation. And thank you so much for having me and inviting me today.
Thank you so much. Peace and hopefully a peaceful night for you all.
Thank you. Thank you so much.